Good morning, everybody, and welcome to this special investigative group SIG Task Force meeting of the INSL Liver Transplant uh, Society. It's absolutely a delight for me to welcome you all today, and we will have a session which is actually limited by time because we have to finish by 8:50 because we have a presidential oration starting at 9 o'clock. At the outset, let me welcome you all and a special welcome to Nazia sitting here. You may not be knowing, she is a famous hepatologist from Toronto and the president of the ILTS. Yes, so we welcome you a lot, and you certainly your presence makes makes our session more interesting. We are waiting for some more experts or panelists. I hope they would. George Soin is around. I think he'll be joining shortly. Arvinder Soin. And we have Dharmesh. He's on the airport. He probably will be joining. And so what the format is that we will start with case presentation. It's an informal case presentation actually. It's a case scenario. We're not going to discuss in depth the case per se, but we'll discuss the concepts, what we will do in a given situation. So there will be a case for about 15-20 minutes, followed by two oral abstracts, which will be presented by two young, bright hepatologists. And then in the last part, we will be having a 10-15 minutes discussion on how we can contribute to enhancing the activities of liver transplant or transplant hepatology per se, or other aspects of liver transplant which are actually associated with the INSL, how we can contribute to that, can we have a task force, and how we can, create a more conducive environment for transplant in the country. And that will be an informal discussion at the last part. So I think with the time constraints, we will start with the first part, which is a case scenario. So may I request Nazia to please come on the dais, please. Dr. Pamecha, he's my co-moderator. He's actually the very top surgeon in our country in ILPS, an expert in liver transplant, and very delighted to have him here as a co-moderator with me. We always want a surgeon to be with us in this session in the SIGs all the time, because we think that our knowledge increases a lot in the presence of expert surgical colleagues. Otherwise, we keep on talking hepatology among ourselves. Hopefully, the other panelists will be joining shortly. So for this case, we have three panelists, which I understand, Dr. Mallikarjun, Dr. Satsangi. Can you just stand up, please? Come on the front, please. May I request the panelists to please come on the front row, please? And if a mic could be given to the panelists so that they can answer the questions as they come. And Dr. Swapnil Dharm, who's again my colleague from my previous institute in Vedanta. So, as I said, this is a case scenario. We are not going to discuss the case nitbit, which is going to have a concept as to what would be what done by a panelist, what they would do, and then an expert as what would you do in this sort of situation. So we'll start with this case scenario. This is actually an actual case, a 41-year-old male who had an advanced end-stage alcohol-related liver cirrhosis, and he had advanced disease, CTPC, high MELD, underwent a right lobe liver, living donor liver transplant. Donor was his brother. GRWR 0.7, uneventful surgery extubated on day 1, then was on standard immunosuppression post-transplant of prednisolone, tacrolimus, and MMF. So, such a patient doing well, but then we find that from day 3, day 4, his enzymes start rising, his bilirubin starts rising. And on a day 7, we find that his bilirubin is 11, enzymes are AST 230, ALT 350, GGT 750, INR has jumped to 2, TAC level was acceptable 8. Standard practice, sepsis screen is negative, culture is negative. The ultrasound liver Doppler shows a normal looking, vascular flows, and nothing there. The basic viral markers are negative, CMV-DNA is negative. So this is the case scenario. You could have a similar case, in your department or a similar setting. Basically, we're dealing with a situation on that at the end of first week, there is a graph which is now not working the way it should have been working. So I have a couple of issues which we would like to discuss step by step. And we'll start with the top one and then take the opinion of the panelists and as well as the opinion of the experts as to what would be done. So next steps in management. It's an open thing, anybody can answer, but maybe I just, because I know Swapnil more than anybody else, so can Swapnil, would you add on to this? At this situation, what do you think is happening? And as a hepatologist looking after this patient, what would be your next steps in management?
So here we are discussing the case of post-transplant graft dysfunction, and all the necessary workup has been done. But I think I would go for a cross-sectional imaging like an NCCT abdomen plus chest to rule out any undrained collection, to rule out that. And if that is negative, then probably we'll like to go for a biopsy to rule out rejection.
Okay. So you say you would do some imaging like a chest, a CT. Why chest CT?
Non-contrast CT of the abdomen.
Abdomen,
Yeah,
okay.
to look
And
for
then,
undrained collections.
okay.
Yeah.
So you are someone who would look for a biopsy, okay. Uh, now, we have Nazia and Dr. Pamecha. So maybe first I'll ask to Dr. Nazia. Now, what is your comfort zone? As Swapnil says, he might do a biopsy if there's a need. What's your comfort zone for a liver biopsy in a setting like this, very early on? And also because I know you have an experience in both DDLT and LDLT, because I know you a lot of publication in LDLT. So you are the best person to say how you look at a biopsy in a situation like this.
Yeah. Good morning, everyone. So in our program, we do practice biopsy in that setting. We are pretty open to do the biopsy. I mean, the INR is high, it's 2. So if we would have to do a biopsy, either we have to correct the INR or ideally do a transjugular liver biopsy. But we are open to do a biopsy and ensure that there's nothing else that are missing. However, clearly, this picture looks like early allografts dysfunction, small for size like here.
Thank you for the inputs. Dr. Pamecha, as a surgeon, I am aware that the concepts which we follow sometimes are not actually, same thing which happened with the surgical colleague. I've seen it very, very commonly. Now, I think that, as Swapnil said, he'll do one imaging. Are you satisfied with that imaging, sufficient to go ahead further with an invasive procedure, or you will take a different route?
So the way I will approach this situation is actually, we need more information as well here. So we need to actually from where we started and where we have come. So in terms of, we really need to look at the trends of this LFTs and also cytopenias, what is platelet doing, what are the counts and all. Those information is very important actually. And then the clinical context, how the patient has been actually, because this he's got a MELD of 24. So I think it's important to know what was the MELD driving. Was it a high bilirubin at that time? And then, so obviously if somebody who has got a bilirubin maybe in this situation was about 15 or 20, then it is going to take a time. But you don't expect day 7 in a partial liver graft to bilirubin to normalize at that early stage as well. So those contexts are very important actually to assess. Then, the thing which doesn't fit into is there is transaminitis persisting on day 7 in a partial liver graft. Again, there has to be a reason for it. Because most of the time the transaminitis, you don't see those peak transaminitis in DD, like in DDLT, it will be around, to start with, it will be around 1,000, 1,500. Those can happen, but in partial liver graft, in diagonal liver transplantation, the day 1 will be around 300, 400, and then it will come down. For somebody to have a persistent transaminitis on day 7, again you need to look at vascular causes very closely actually as well. So I'll agree that we should do a contrast CT in this situation if KFTs are permitting. So if the creatinine and all is okay, you should actually do a contrast imaging, and you can find other causes as well. So if there was an inferior vein which was reconstructed, you may find there may be thrombosis, or a middle vein might be partially thrombosed as well. And these are important causes actually to rule out before we start labeling into early graft dysfunction. So that will be my approach.
Yeah, I was interested in knowing those, last bit you answered actually, that as a surgeon, you like to look at the MHV, what the construction you did, would look at the, IHVs and all. Is this anybody would do an MR imaging at this stage, any MR, MRCP, or no, you think it's not of use?
Won't provide much information, because if there has to be a biliary issue, ultrasound will show some IHBRD, but But if you are doubting and what type of reconstruction you had, and then there is something that the biliary anastomosis were not those, maybe you had multiple ducts and you're doubting, then it's better to do it. It's always good to have more information rather than not having it.
Nazia, what was your call on that?
Again, I agree. I think that if you have a good contrast CT and a good ultrasound, likely MRCP or MRI would not be helpful. But it's also, it's nothing prohibiting to do that. I was going to ask also a question about the graft itself. So you mentioned GRWR is 0.7.
Yes.
What was otherwise the quality of the graft was good, not steatotic,
No, it was
young donor, and
yes,
because that's also important.
Yeah. That's a good quality graft. His patient is 41. The donor was younger to him, and it was not one of those steatotic graft. It was generally looking okay, except that the GRWR, if you may say, was on the low side. So the question then comes is that, as you said, you might like to do a biopsy. Well, we see Dr. Soin walking in. Can you just join us on the dais, please? Not really. So, not to repeat the entire thing, but you would have led the case scenario. We're just developing on that and discussing a patient who had some graft dysfunction on day 7 post-transplant LDLT, and 41-year-old male. 0.7 was the GRWR, and his bilirubin on day 7 was 11. ALT were 230, 270, and Dopplers and VAS were normal. So there was an opinion that we do an imaging and we do plan liver biopsy to look forward as to what could have been the cause of this. And there was a concern that is a biopsy safe enough, or is it something valuable which one would like to do? So as you have just walked in, because people are really keen to know Dr. Soin with a very vast experience, one of the top surgeons which we have worked through and in the country and across the teams all over. So Avi, with this situation, I'll really involve you straight away because I don't want to lose the opportunity of you having here. So a graft dysfunction day 7, otherwise okay, things are fine. What would be your call on an invasive procedure, because the panelists thought that they would do a liver biopsy. Swapnil was actually in that involved. So what is your call on that?
Right. So obviously you have to exclude other causes, specifically infection and rejection. Infection obviously is not going to be ruled out by a biopsy, but rejection, yes. So it'll be rejection versus reperfusion injury or early graft dysfunction in other ways that will show up on biopsy. So one assumes that all the infection parameters have been ruled out. You've done your procalcitonin, you've done your total leukocyte counts, you've done your scans of the abdomen, and cultures are negative, and hemodynamically and arterial blood gases wise the patient is stable, there's no high lactates. So if all that is good, then what has been the progression of the LFT, and what was the patient to start with? Like what sort of CTP MELD are we talking?
Yeah, he was a sick patient. It was CTBC, MELD24, was a sicker guy to start with.
Right. And what was the progression in the first 5-6 days?
Okay, so he was okay in the initial part, and then he, from day 3-4 onwards, his LFT started worsening. So we were actually more interested in a conceptual thing that if there's a problem on day...
what's happening to the INR?
About 2, INR's 2.
INR's 2 right now?
Yeah, that's right, yeah.
Trending down or up?
It's trending up, actually.
Okay, and what about acidic drainage?
He had been pouring about 1.5 liters of fluid every day.
Again, up and down? Or
yeah,
down?
It's been sort of going on for the last 3-4 days.
Right. So I think this is very likely to be a non-rejection cause, early graft dysfunction. So if the platelets are good and if the other situations are okay, then I don't see a problem with doing a transtubular biopsy.
So I think that's a very useful point you put in. I think that is a very useful information which we get here, that if there's a need we can go ahead. Now Mallikarjun, can you just say, now we all talk of early graft dysfunction. That's what probably Nazia mentioned as well and Dr. Pamicha mentioned as well. So how do you actually define early graft dysfunction? We know there are definitions which are there for DDLT. Now, what would be your definition in practice for EGD?
Yes, sir. As you know, sir, there is a lot of confusion there in the definition also. There are many people have proposed different ways of defining it. One of the what we everybody is now start accepting at the day 7, if the enzymes level are more than 2000 and bilirubin is more than
See,
10.
that is the Althoff definition you should make,
Yeah.
Kim Althoff. So I always a problem with that, but that's a DDLT definition. I mean, I don't know. I mean, I'm yet to see, 2,000 enzymes, we have been, thousands of patients we have done.
Yeah.
So, I mean, what is your call on that?
Hardly ever see those.
Yeah. So that's probably redundant. In fact, unfortunately, what's happening is that many of our studies which we have done, or not I have done, we see are being published, they are in LDLT and they follow this, Althoff definition. So I personally feel that that is probably not. Satsangi, what's your opinion on that?
So I agree with you, sir. I mean, predominantly when I work in an LDLT setup and we don't see the enzymes going that much as a DDLT setup. So here we would rely mainly that in the first 7 days, a lot of pre-operative or peri-operative factors which drive the issues. So EGD would be defined basically after the day 7, day 8 mark, wherein the bili is important. If the bili is crossing, say, 9, 10, and if you have a coagulopathy, INR crossing your upward trending more than 1.5, 1.6, and especially if there's a lot of ascites and kidney dysfunction, if your ureas or creats are going up, that would be an important thing for EGD.
Okay.
So just a quick comment on DDLT versus LDLT. You see, the DDLT situation is where you actually had a ischemia reperfusion injury in the form of preservation injury, right? Or a bad quality liver like excessive steatosis in the beginning. So that situation is quite different from when EGT normally happens in LDLT, which is generally to do with a good quality graft, which is possibly low in graft to recipient body weight ratio. And that is a hyperperfusion injury. So those two things are quite different. And that is why you get high enzymes in the DDLT definition, which most people agree with. And we hardly ever see high enzymes. You often have a bilirubin of 10 and a SGOT-PT of like a 60 and a 80.
I completely agree with you. Yeah. So now I understand Dr. Pamecha has published on EGD, from his center. So probably he would like to contribute to his, knowledge in this. What would you say, Dr. Pamecha?
So the way I see it, we still haven't defined it properly. That's what I will say. Because the definition is, most of the definition starts on day 7. Althoff also does have transaminitis, but then they have or bilirubin of more than 10 and INR of more than 1.5 on day 7. The only thing with Althoff is it is index 1 time reading on day 7, and it defines that. So that's the problem with that definition, because on, if you're just taking day 7 count, you're not taking any dynamicity into it. So it is very sensitive, but it is not very specific. So there will be lots of patients who will satisfy this definition. And actually overall data will say around 30-40% of patients in good volume center will satisfy that definition. So that's a very high number. But the outcome of that, in terms of patient having increased morbidity and mortality, that is not reflected by that definition. So that's the limitation of Althoff. So what we try to do is we try to look into the dynamicity, and we had after day 7 for 5 days bilirubin, INR, and we also found urea was important. And the dynamicity is important because there can be infection, there can be other causes which can cause bilirubin and INR to be high on day 7. So when you're looking at consecutive day 5s, then you know that you already treated everything else which could possibly lead to this. And now after day 5, by the end of the day 5, you still having this high bilirubin, INR and urea, then you probably are dealing with an early graft dysfunction, which probably is not going to respond to whatever other treatments you want to do. So on that basis, the reflection of that definition is that if you want to think about retransplantation, that's a very, very tricky decision in live donor liver transplantation, because to tell family that this is not going to go ahead and need a retransplant, or to list a patient for retransplant. So that's where the value of that definition comes in, that these are patients who are not going to do well, and they will have high mortality as well. So once those patients satisfy that definition which we have proposed, the mortality actually goes up to 90%. So that's the tricky part of that definition. That's why the importance of the definition comes into play.
Right. So I think there is a bit of ambiguity, and we need more knowledge, especially in
So,
LDLT.
if I'm allowed to,
Yeah.
just one more comment I'll make. Why I said that we still haven't defined it properly is because we're trying to define everything by biochemical means. So we got an INR and bilirubin. We're not taking patient in context, and I think that's where we need to look into, like we define post-hepatectomy liver failure. So you have a biochemical problem, you have a clinical problem. Clinical problem requiring an invasive treatment, and a clinical problem not requiring an invasive treatment. So that's how actually you should grade this definition. And this is important because then there are lots of extrahepatic things happening in this patient, which don't get reflected into this definition and all. So there can be effusions, there can be respiratory infection, which all will not actually come into this definition. And I think that those are very important contributors to what actually happens to the patient in the end. So I think that's where the evolution, I'm sure that that part will come. It is just that the process of understanding and that is
So
taking time.
I totally agree. It's a very useful point you said, Virendra. Now, Nazia, you are actually, in a very, detailed, dense area. So two small questions in the same continuity. One is that when do you consider as EGD on the definition wise, and as because we, having limited time frame, when actually this also people should know, when do you advise a retransplant for your patient LDLT? Because this is something which we never discuss. And our scenario is totally different from a DDLT. So because of your excellent exposure to both, so what would be your call on these two things?
Yeah, so just to, is it on?
Can I have the mics on, please?
Turn it off. Sorry. So just in terms of definition, again, I fully agree. DDLT and LDLT, early allograft, early dysfunction is very different. And DDLT, we have high elevated liver enzyme in the setting of perfusion injury, which doesn't apply. LDLT, I think that, I agree that elevated bilirubin above 10 or whatever number you want to give, and high INR at day 5, 7, especially if the INR is climbing. And ascites would be the definition that we would use in the setting of EGD for LDLT, at least in our center. As for retransplant for LDLT, we tend to do retransplant only if we have a HAT those are clear retransplant. In this scenario, we would start with pharmacological treatment and then escalate next to splenectomy.
When it's a pharmacological, just give it one or
we do octreotide. We start
Octreotide.
immediately with octreotide for a few days, and then we move on to splenectomy generally.
Yeah. Okay. So, Dr. Soin, for maybe the last comments on what would be your approach to this sort of treatment point of view, especially with an emphasis on retransplant for the education point of view.
Right. Okay. So I don't want to repeat the stuff that you treat the treatable stuff, which has already been said, which includes vascular infection, biliary, and rejection. But infection and EGD are closely intertwined. So one can lead to the other. You may start with a graft of GRWR 1%, but you still may land up with a functionally poor graft because there's been infection and damage, right? Or for that matter, from a HAT which has been treated. Right. So then you can have a secondary EGD. So retransplantation is a very tricky thing, and I agree with Nazia, we hardly ever propose retransplantation for EGD patients. We treat the treatable causes, and we found that when there is no infection, then plasmapheresis, 3 to 5 settings, sometimes even 7 cycles does help. And we're actually putting together a manuscript right now of our entire experience with plasmapheresis and about 40-odd patients with EGD. So you will have some evidence, but believe me, it does help. I would say 40 or 50% of the time when there is no infection. But there is infection, then you're stuck.
Right. I think that's a very, very important point you mentioned, and yeah. So we have to. So what we understand from this discussion today, that there is an entity EGD which we have to understand. There's no more definition needed, and you have to be aware of a situation which could be leading to retransplant also. So that is really important to understand. So I think what we'll do is, because we have oral papers after this, we will stop at this stage. And I profusely thank our experts. We really are,